Hi everyone, welcome to ABC's Anesthesia on YouTube and on the podcast. And today we're extremely fortunate to have Mr. Timothy Chilborough with us. He is a distinguished consultant surgeon specialising in general, trauma and colorectal surgery at the Royal Melbourne Hospital here in Melbourne. So Tim's research focuses on inherited colorectal carcinoma, minimally invasive treatments for colorectal cancer, and his expertise also extends to rectal endometriosis and inflammatory bowel disease. And additionally, Tim is deeply involved in teaching and mentoring junior doctors, serving as a mentor and role model for many. And so I was really fortunate to have Jason, one of the PGY2s at RMH, reach out to want to contribute to ABC's Anesthesia and got in contact with you, Tim. And so thanks so much, Jason, for bringing us all together. In this series of conversations with surgeons, I really want any anesthesia provider, of any level, really, whether they're, nursing or, junior doctor or anesthetic trainee, just to get an insight into the surgeon's perspectives, because a lot of the time we don't have that. When you start training, you're in your little bubble and you have these brief conversations with surgeons. So Tim, just to get started, this is like a question I think is really important because it really defines your long-term career. If you get along with your surgeons and you do a good job with them, they provide you with work if you're in the private system, but also in the public system, it just really, it evolves into a good relationship. So what signals give the impression to a surgeon that their anaesthetist is competent, on the ball, someone they want to work with in the future?
Communication's a huge one for me. So I think having a good narrative with the anaesthetist you work with before, during and after the case really is the signal to me that an anaesthetist is really understanding of the surgical pathology, also the operation we're doing, why we're doing it, how we're doing it, and how that impacts their anaesthetic and the patient's post-operative course. And I think we all have anaesthetists we trust, and when you're faced with a difficult case, either in the emergency setting or the elective setting, for example, advanced cancer or a difficult procedure, there is nothing more reassuring to the surgeon as to knowing that the person on the other side of the drapes is looking out for your patient and looking out for you and the team on the day. So I think communication and just overall understanding of the surgical pathology and the plan is really the most important things for me.
And I know that in the public world, obviously, I work with each surgeon quite infrequently. And if it's just a general list with pretty relatively straightforward elective cases, I don't make too much of an effort for the call before. But generally, if I have the big liver cases or the cancer cases or something that's a bit unusual for that list, I'll always give a call or a text to the consultant surgeon beforehand. You're pretty happy to receive those? I know you guys are pretty busy with
Yeah, very happy to receive them. I think most of us won't have much to tell you for the straightforward, elective hernia repairs or the scopes. And often, the responsibility is on us as well to reach out and say, we've got a difficult case. It's going to be a challenge for the anaesthetist for so-and-so reasons. For example, a difficult area, usually we'd reach out to the anaesthetist and tell them and make sure it's on the booking and the patient and the anaesthetist is aware. But yeah, if there's any, certainly occasionally you have an anaesthetist who haven't done my specialty or haven't had the exposure to some of the procedures we do, want to ask positioning or what sort of anaesthetic you'd want. And so always very happy to hear in the pre-operative phase from the anaesthetist. Certainly more communication is usually better and helps build that relationship and trust.
Hey, that goes on. Do you ever have much of a preference for the anesthetic? Say, our options are broadly speaking, TIVA versus volatile for the anesthetic itself, or the kinds of opioids, the kind of pain management. Do you have much opinion about that?
Yes. So, analogy I'd give you is that I think the safest way for me to do an operation is the way that I do it day in, day out. And so that I wouldn't change my operative technique if you came in and asked for a particular type of operation. I would offer you the operation that I recommend, the way I best know how to do it. And I wouldn't, for the same reason, I wouldn't ever dictate the anaesthetic to the anaesthetist. So I'd be very much happy to take their advice, and that would be different depending on the anaesthetist of the day. So I often do find myself in a situation where I'll have the same procedure, and some patients will have had the addition of spinal or intrathecal morphine, and other patients, other anaesthetists don't feel that's necessary. And I'm very happy to be led by the anaesthetist from that side of things. From the surgeon's point of view, we like a smooth takeoff and landing, and and we like to be involved with the discussions, but we're fairly flexible. So I quite like the use of tap blocks laparoscopically and open, placed by the surgeon, and I do like to try and reduce the use of PCAs and things for our laparoscopic and robotic cases where possible, or at least getting them down the first day after surgery. But that's all fairly negotiable with the anaesthetist on the day.
Yeah, makes sense. Jason.
Hey, Tim. And was just wondering, what are some of the key considerations that you will discuss with an anaesthetist prior to procedure?
So the big ones are the type of anaesthetic. So obviously for our more minor procedures, we're happy with scope to things with sedation, running through to LMA to intubation. So there are specific needs for there. Usually they're fairly standard. Positioning is a big one because we're somewhat greedy, sometimes particularly with our laparoscopic procedures and robotic procedures. And if we're working on both sides of the bowel, doing a subtotal or total colectomy, then I'll often be demanding an ask for both arms in, which is, I know, not the favourite of the anaesthetist. So I usually apologise for that. And also apologising for the steep head down that's required for some of the difficult pelvic procedures.
I actually really appreciate that because, if anything I've learned over time is that it's just better to have the surgeon do the best that they can in that time frame, and for us to suck it up a little bit, because afterwards the patient will probably do better regardless. But it is nice that when you ask for the arms and you get, I'm sorry about that. That just feels better to me when they say, I'm sorry, but we need this, and we go, okay, that's fine. It was one of those things that, just not being able to see that drip, we get very anal about not being able to see a drip, but it's just one of those things to deal with. The other questions I often will ask, just for the audience, the position, obviously, where the arms are in really matters to me, because then matters which side I might want to put the drip in and the outline, whether they need paralysis for a specific operation, the airway type, especially if it's airway surgery, but antibiotics is very routine, DVT prophylaxis options as well, very routine, and often the length of the time if they're expecting anything crazy to happen. You mentioned communication before. What qualities besides that do you value most in these anesthesiologists and anesthetists? And I'm thinking these days, I guess efficiency and speed or the decisiveness. These are the qualities I imagine.
Not always. I mean, we know that all of us, the same as the surgeons, a bit of a spectrum between speed. And that's not so much of a concern as long as you're sort of not way off the end of the chart. Most of us are happy provided things are progressing along. We really like anaesthetists that consider the patient's wishes, listen to the patient, and look after them, and are open to providing support in the perioperative period, whether it just be phone calls or providing advice and communication with us. So I think I had a patient recently who made a complaint about an anaesthetist I worked with because they were perhaps a little bit dismissive after one of their anaesthetics, and they had a bit of atelectasis and required a prolonged period in recovery and some oxygen, and really stressed to me the importance of communication at all levels, from the whole surgical team, and listening to the patients. I think that's very important. I like clear communication. I like decisiveness, and I like it when the anaesthetist tells me if things are wrong. So sometimes you'll hear rustling under the drapes, or you'll hear the monitor, you hear the beeping from the anaesthetic machine, and often I'll ask what's wrong, and sometimes you won't hear anything, and you have to stop what you're doing and look up and see. And if there's issues from the top end, we like to know about it, because there are often issues at the bottom end as well. Things we've caused, for example, bradycardia from pneumoperitoneum, or hypertension from bleeding. So I think communication is probably the one main thing.
Yeah. This might be an old school kind of thing with the surgeons I worked with back in the day, but we have this thing in anesthetics that we just say short sentences, and it's part of just the efficiency. But I think there's some levels of cerebrality, and anesthetists, often we can be very verbose in kind of talking about all the different physiological aspects that might be just irrelevant to your interest and what you need to know, and just being able to go, yeah, bradycardia, stop what you're doing, I'll be 30 seconds or something like that.
Yeah, no, I certainly agree with that. We're not as smart as you guys with the physiology side of things. We do cover it in our part ones, but I think your exam is much harder than ours. So yes, I think keeping it short and succinct is good for the surgeon.
Yeah, no, that's good. Do you find you go, Jason?
I was just going to ask, what do you find then are some of the sources of tension or / conflict between the surgeon and anaesthetist?
Yes, adding the extra case is often stretching the friendship. So and obviously it's different in public or private. So I think finishing on time is always a stress. There's often pressure for us to complete things in a reasonable time frame from multiple sources, whether it be competing interests on the ward, the nursing staff, and the anaesthetists, everyone wanting to be out of there, but we're always got our patients in our mind and sort of tunnel vision for the operation. So I think sometimes that can be a source of conflict. I don't tend to find many sources of conflict on a day-to-day basis with anaesthetic technique or post-operative course. I think most of us are fairly understanding and flexible and respect the anaesthetists. The other time we occasionally have conflict is with patients that are very high risk and assessing their overall operative risk. And sometimes we think we think they're better than they are, the patients, and we need to be brought down to earth by the anaesthetists and the perioperative physicians as to how marginal some of our older surgical patients are, which is becoming an increasing problem. But I wouldn't say there's huge tension or conflict among the groups.
That's obviously really good to hear. And it's one of those things where it's almost like the system is set up to, like mentioning the add-on of the patient. You have your patients that are yours, they have to get done at some stage. And from your point of view, you just need to get them done as soon as they can because they have a definitive problem to solve that's surgically correctable. And you can just see how much value there is in having a surgeon that pushes for their patients to get done. But then from every other staff member in that theater, they just clock off at a certain time and they will see the next patient the next day and it just keeps coming. And it's almost like the system isn't set up to reward that.
That's certainly true. And it's hard for us because I have to see all the patients in the outpatients clinic. They call the liaison nurses. The nurses email us and call us and say this patient's got increased symptoms. They're not coping at home when we do their operation. And we've got, particularly over COVID, we just had hundreds of these patients who were, waiting for surgery and we couldn't treat them in time. And I would say one of the conflicts we have had has been extra lists. And most of the surgeons are pretty keen to do twilights or weekend lists in the public to clear our waiting list. But we just have had a bit of struggle to get staffing from other aspects of the hospital to facilitate that. So I suppose that's one area of conflict, and it's understandable because we have to see the patients and they're sort of on our list, so it's our responsibility to care for them. Whereas the other staff involved with the operating theatre, the nursing staff, and anaesthetists don't have such a direct relationship with the patient, which makes it challenging.
Wouldn't it be when you see the how quickly get things done during hours versus after hours, even just we have a fee-for-service model, and that, oh my God, that promotes some serious efficiency on all sides. I just imagine how great that would be for everyone, even the nursing staff, to get some level of bonus for just for running through cases.
Difficult. We don't have that model, and I'd be jealous.
Yeah, that's right. Now, occasionally we have some level of crisis in a theatre. What role would you or most surgeons be comfortable with being allocated to during that? Like, say it isn't a blood loss that needs surgical correction, but it is some level of other physiological crisis. What would you want us to ask you, or what are you pretty comfortable doing? What are your colleagues comfortable doing?
Could you give an example, perhaps? Are you thinking like an anaphylaxis or
anaphylaxis or a cardiac arrest? Obviously, very different situations.
Yeah. So we're very happy. I think if it's a non-surgical problem, so if it's not bleeding or sepsis related, and that's a physiological type problem, we're very keen for the anaesthetist to take charge of that and instruct us what to do. So we're very keen to help and including being told to stop operating. Some of us need to be told to stop operating and stress the significance of the situation. Happy to do what's required. So, very happy to be led by the anaesthetist.
In terms of chest compressions and things, you got, every medical officer that, and that's
So not unusual for us to have to do that occasionally in the trauma situations. You'll be.
Yep. Absolutely. In terms of the surgical risk, I always think of there's a risk of doing something and a risk of doing nothing, and obviously those are both tangible things. In terms of the risk of doing something, there's a operative risk or the success profile of being better, so improving things, not changing things, and some level of harm. And then there's the perioperative risk. And I always think as a surgeon, you probably have the best longitudinal impression or even data of, let's say you're doing a lap chole, this many patients will be successful, this will have no benefit or the same symptoms, and this patient might have harm. But from a physiological point of view, we often use the NESQIP or the riskcalculator.facs.org. Do you have a sense of where you get your data from for the perioperative and surgical risk?
Yeah, so there's a lot of us will get a bit of an overall frailty assessment of the patients from seeing them and knowing them and working them up. We will routinely send our frail patients to the perioperative physicians for the NESQIP assessment. I think there are some things that over-assesses and some things that it under-assesses.
Yes.
So that we always sort of take the results with into consideration. I think what we don't talk about enough with the patients is, we always talk about mortality, and for our bowel surgery, for example, I always talk about the risk of leak and the risk of a stoma. But for many of our old patients, the risk isn't of a major complication or a leak, it's the risk that they'll just be deconditioned and they won't return to their normal place of residence. And I think that's probably a really big one for a lot of our older patients who have a marginal surgical candidates, have non-obstructing tumours, and then are considering surgery or expectant management. So it's challenging. I'm very dependent on our anaesthetists and we've got a perioperative physician team at the public hospital I work at who are very helpful geriatricians and physicians who will help provide that risk and assist in a shared decision-making model. But I always want to discuss with them and the anaesthetist the risks of not doing the procedure. And also discussing the flow on decision making after that. So you've got a patient who requires surgery, who has comorbidities and is high risk, and there's risks of surgery, and there's the likely outcomes, and there's the risk of less than desirable outcomes. And if you don't do surgery, there's no immediate risk, but there's also the risk, for example, for my patients, of them obstructing their tumour or bleeding from their tumour, and then what we would do then, and whether we have less invasive options, palliative options for that. And I think that's always worth considering as well, because having those discussions in daylight hours rather than when they represent 3 months later in the middle of the night is always helpful. So it also puts the risk of surgery into light when you've got the natural history of the disease well understood.
Yeah, I always find that we see someone who's elective and then they're really high risk, and the thing is, elective doesn't always stay elective. The fact that 3, 6 months, 1 year down the track, suddenly it's urgent, and now it's even worse for the patient. And so often, even if I have the highest risk patient, no matter what kind of conversation I'm having of the risk profile, it often tends to go towards some level of operative, but like you said, more like minimally invasive or palliative, or just less of a big cut to try and minimize that perioperative risk. But either way, they need something done.
Another good example I would say with the perioperative risk and discussion with patients is that I do a lot of endometriosis surgery, and this is a benign condition. It's a chronic condition that young women have to deal with, and many of the patients I have are in their 20s or their 30s, and they'll often be faced with the prospect of bowel surgery on the rectum, the low part of the bowel, for endometriosis or not, and the prospect of surgery there would improve some of their bowel symptoms, albeit at a risk of leakage and a stoma, albeit temporary. And it's a really good juxtaposition if you think compared to our cancer patients, because you've got young patients who are informed, and often the discussion with them is actually more difficult because the condition they're going to have for a long while. There's risks of a complication that none of the young patients want. and they have to weigh that up against the long-term outcome of the disease, which is rather unpredictable. So it's actually often a more difficult discussion than some of our cancer patients, because the cancer patients, if we think they're fit for surgery, most of them have no issue accepting such sort of risks, perioperative risks, and risks of leaks and stomas.
That is a great example. In terms of, I haven't had seen many, like in our hospital, we don't have many colorectal surgeons treating endometriosis, often gynae, and then if it gets really beyond that, it becomes a potentially multidisciplinary surgery. What is the success rate of surgical?
Good question. I don't know if I can give you an exact figure. So it's not common. So it's really only certain gynecologists will attack the cases that are involving the bowel, and they'll all have a colorectal surgeon come for that part of the procedure. There are good results anecdotally with excision. But again, we have functional outcomes to consider. So often, really a low part of the bowel, patients will have a problem we call low anterior resection syndrome, where they have urgency and increased frequency of bowel motions. And so if you're replacing one problem, which is the symptoms of bowel endometriosis, which is often painful defecation and pain after defecation, sometimes bleeding, bloating, and you're replacing that with increased frequency and urgency of the bowel motions, you're sometimes just swapping one problem for another. So that sort of leads into a bit more of a nuanced discussion about extent of surgery for them as well, which is a population you wouldn't usually think about, that would need perioperative discussion and stuff. But from a surgical side, there's a lot to discuss.
Yeah. Look, I thought we would actually get onto some specific, and obviously I'd hate to be having to make that decision as a patient, but that sounds really tricky. In this series, it'd be good to go through some specific operations. And since you are a laparoscopic surgery, we mentioned the steep head down kind of situation and also trauma. But the fact that there's often these conflicting things with the surgical environment and surgical exposure and the ease of the operation versus the patient's physiological state. And I remember many times having a very obese patient needing steep head down, where I am absolutely battling the pressures of ventilating someone with, that massive mass going down and a long time frame, versus you guys, the surgeons, being able to do a successful operation and getting the access they need. What's your impression of that problem?
It's very difficult. You've certainly got competing interests. It's very challenging. Many of those obese patients are very challenging to manage surgically, either open or laparoscopic or robotic. We know that our complication profile is better, particularly with things like wound infections for laparoscopic. Mm-hmm. But there's no point having that if we've had a very prolonged head down and you've had trouble ventilating the patient for so long. So often I find that's flagged at the pre-admission clinic for patients that we think may be better done open. Often we'd still put the laparoscope in and see how they tolerate the pressure, but I wouldn't usually be upset. And I think a little bit of an issue we have is that now that we've gone so much into minimally invasive surgery, that it's becoming the standard for most procedures, that many surgeons will consider open surgery a failure. And so I don't think we should consider open surgery a failure for any reason. So sometimes it's surgical pathology, sometimes it's inability to tolerate the pneumoperitoneum, sometimes it's the equipment factors or not being able to obtain a good view. There's nothing wrong with open surgery. We know that laparoscopy is probably a little bit better, but it's got to be safe by the patient and it's got to be safe for the surgeon. So when I see a patient in the clinic, I always talk to them about open surgery as well. And I say, there's nothing wrong with open surgery. You have a bigger cut. You're in hospital usually only about a day longer. Mm-hmm. But the main thing for our bowel surgery is making sure we remove the bit we want to remove, don't damage the things we don't want to damage, and do a good join, for example, for our resection. So, and I say most of the time we do that laparoscopically without problems. But if there are issues or I wasn't happy or the anaesthetist wasn't happy, then we just do it open.
Yeah. And so it's an interesting thing, because one almost speaks to longer term problems, whereas in the immediate term, that's what the anaesthetist is faced with. So I think over time I've realized that I'd rather the surgeon has the best exposure that they need within reason to do the best operation they can, because a lot of the, a lot of the time when we do studies into perioperative mortality, it's not the anesthetic. As long as the anesthetic goes reasonably well, all the perioperative morbidity and mortality is in the next 30, 60 days. And so it's better that we target the best conditions for the surgeon to operate. But now you've probably seen the spectrum of patients with different anesthetists and the severity of what the head down does to their physiology. Do you have a sense of how long you've had a patient at a certain end-tidal CO2? When we can't ventilate, the CO2 goes up. We worry about that. But we know from other cases of like severe asthmatics who had CO2s that are unrecorded, that it's a very forgivable problem. Unlike metabolic acidosis, respiratory, we just blow it off at the end once they're in recovery or in ICU, and people almost invariably recover. Do you have a sense of that?
Probably not as much as I should. That's the truth. I think it's difficult with it. It's certainly, I've worked with anaesthetists who are more cognizant to it than others, and I think often when we're in that situation, we try and reduce the head down for parts of the procedure. Mm-hmm. So for us, for me as a colorectal surgeon, it's really just the rectal part of the operation. And so if you're doing the rest of the bowel as well, for example, if you're doing a proctoclectomy, you won't need the head down for the rest of it. You may even need head up. So sometimes it's limiting the time and communicating with the anaesthetist and making sure it's tolerated. Mm-hmm. And the other thing sometimes we would do in that situation is a hybrid approach. So if you've got, for example, often we'd be able to do the laparoscopic, the colon part of the operation laparoscopically, but I can't get the rectal bit done laparoscopically or robotically for whatever reason, because of anatomy, because of not tying the head down or for any other reason. Then often I would do a fan and steel limb if I'd done all the rest of the mobilization of the bowel. And so you're getting some of the benefit of laparoscopic, but you're also not faffing around if you've reached your limits and can't do it. So you're sort of splitting the difference, and you've still got an incision that's not a vertical incision that is reducing your risk of both pain and hernia, and infection. So I think that's worth considering as well for some of our pelvic things.
Yeah. Hey, I always thought, just from what you mentioned, an open operation, they're in hospital for one day more, a bit more pain, a bit more healing to be done. And my sense is that in the sicker the patient, say, imagine someone with some level of heart failure, but they're stable enough, low enough risk profile to go ahead with the operation. But I really want this patient. We really want this patient to have a laparoscopic operation, so there's just less wound healing. There's less metabolic demand on the patient. Do you get a sense of that laparoscopic in the sickest patients is far better, but by magnitude, or by?
It's definitely better. I think it's hard to say it's far better. Because most of the patients will still get through an open operation, but they'll often need more support. Mm-hmm. And I think the other thing you have to discuss in discussing open and laparoscopic surgery is ERAS and the role of ERAS. And all of the original trials in ERAS in Scandinavia were done with colorectal surgery, and they were all done with open surgery. Mm-hmm. And if you look at the results, they were pretty similar to some of the laparoscopic, certainly the initial laparoscopic results. So a lot of it is in the perioperative care as well, and getting the patients up out of bed, controlling their pain, multimodal analgesia, and feeding them early, and doing all those other things which we do instinctively and innately with laparoscopic surgery because they have less pain and they're up and about and they're doing all these things anyway. But you can still do it with open surgery and get almost as good results as what I would think.
Oh, that's really reassuring. I think that's probably what we wanted to cover with kind of the head down laparoscopy. Do you have an opinion about anastomoses and vasopressors? And a lot of the free flaps that we do with where you're transplanting arteries, the plastic surgeons absolutely want no vasopressor. Is that not similar for what you guys do with anastomoses?
It is. So most of our patients won't be on, in the elective setting, wouldn't be on any vasopressor support at all. So in the elective setting, it's really not an issue. Mm-hmm. For our emergency patients, there are reasons where I wouldn't do anastomosis, and that would mainly pertain to physiologic instability. So if they were on more than a single-digit amount of noradrenaline or metoprolol, then I probably would be unkeen to join them, and we'd be more likely to form a stoma. Again, it's the discussion regarding anastomosis and stoma is always a very difficult one, because you've again got competing interests. So you're on the day, you're probably making a safer choice by doing a stoma. But we know for some of our procedures, particularly Hartmann's procedure, where an encostomy is formed, the rates of perioperative morbidity for the subsequent reversal are quite high. So there's a real difficult discussion to have, and it's very hard to know what the right thing to do is, whether you accept a slightly higher risk of leak on the day to reduce the risk of the next operation. But of course, many of the patients won't go and have a subsequent operation. So it depends on the patient's premorbid condition and their ability to tolerate this operation and potentially a next operation. So it's really difficult. The other big factor for us is contamination. So usually if I'm working on the bowel and doing an anastomosis and the patient's on a lot of support, then usually it is because they've had peritonitis and perforation, and that's a huge consideration as well. Some of us will use, for the really sick patients, we'll put them in ICU with a vac dressing and bring them back in 48 hours when their physiology is better and join them. But otherwise, we would just make a stoma if we weren't happy. But yeah, I would share those concerns. But yeah, it's a difficult risk-benefit discussion, and it's not straightforward.
And a lot of this, we just don't have the data, really. We don't know what amount of this in a specific patient, or the amount of head down, the amount of CO2, the time, all the factors at play. It just, we just don't, we're not seeing data or evidence on either way.
Yeah, it's very, very difficult.
Hey, Tim, I think that's been about 30 minutes, and I think we covered a lot of ground there. Is there anything else worth bringing up before we sign off?
Not that I can think of.
No, that's good. Hey, thanks so much for coming on the show and just being really, really forthcoming with all candid discussions like this. And I think it will really help anyone kind of listening out, especially those starting out in anesthesia. So thanks very much for your time, Tim. And
no worries. Thanks for having me.
No problems at all. Now, what's new with AV Systems Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.